nerves coming from the sympathetic chains. This is all familiar to you. They're actually, for the GI tract, those splanchnic nerves are going to go to these, the general term is prevertebral ganglia. So they're just they're located on the anterior surface of the abdominal aorta. They're not organized very well. In a dissection, you can kind of detect these things there, but they're not like spinal ganglia, nice and contained and packaged up neatly. But you see these prevertebral ganglia, and some of them here are shown associated with the aorta. So here are the splanchnic nerves carrying preganglionic fibers. Synapses occur in these prevertebral ganglia, and then the postganglionic cell fibers are going to just hitch a ride on the arteries that are running through the mesentery, and this will take the fibers then directly to the wall of the GI tract where they'll innervate the smooth muscle of the GI tract. The parasympathetic is going to, of course, come from the vagus nerve. These are preganglionic, which are going to come down, they'll follow the esophagus, down into the abdominal cavity, and then they too will go to these pre-aortic ganglia, but they'll just pass through. They won't synapse there, but then they'll follow the arteries that go out to the wall of the gut, and then in the wall of the gut, these fibers will synapse with postganglionic parasympathetic cell bodies, which are contained there in the gut. So unless there are questions about that, we'll just kind of leave that. The only thing I would say is the vagus nerve carrying the parasympathetic fibers reach the foregut and midgut derivatives. They don't reach the hindgut derivatives. So the distal end of the transverse colon, descending colon, sigmoid colon, I'll ask you this question, where do those components get their parasympathetic innervation? Any takers, did I hear? Sacral nerves, so S2, 3, and 4. So the spinal cord segments S2, 3, and 4 are going to supply the vagus nerves that reach the hindgut. So we're not going to talk about pathways there. So that's, okay, so now what I'm going to do is go to this next slide set that I call labs. So I start off with, you're not seeing it there, but if you're looking at it, I start off with several VHD cross sections. But what I want to do is go a little further down. It looks like slide 15 here. So if I go to this slide, is everybody with me on here? So these, I want to go through just the next 4 or 5 slides and talk about like how to interpret these images. These are similar to Netter drawings, but done by somebody else. This is from a TEMA Anatomy Atlas book. So what we're looking at here, we'll just start here. We've just taken the anterior abdominal wall off. And this person is facing, like here, I'm facing me. We've taken the abdominal wall off and we're looking at the posterior surface of the anterior abdominal wall, right? So what can we recognize here? I know you've done the muscles, we won't worry about that, but this shiny layer right here, which has been cut through, transected through there, but it's intact. Oh, you can't see the pointer? Yeah. There we go. So you're oriented to the overall picture right here. So here's this shiny layer right here. It's got a little section taken out. Here it's intact. What would this layer be? What would this first layer be right here? Yeah, that's parietal peritoneum. This is from Rowan's Atlas, just showing some of the same thing there. But so now we've opened up the abdominal wall. Of course, the parietal peritoneum would be right here. It would be right here. And so if I put my hand here, or you put your hand here, it would be it's in the abdominal pelvic cavity, but more specifically, where would it be here? This is the greater sac. So now I have some parts that we can identify, maybe just take a moment, look through this list and make sure this is clear to you. Are there any? Good. Yes. How can you, so are you referring to one of my, something on the list or just in general? Yeah, so we have the peritoneal cavity, and then we subdivide it into greater sac and lesser sac. So let's talk about those two sacs. So of course, someone has already pointed out that this whole area we're looking at here would be greater sac. And even if we picked up the end of the greater omentum here and lifted that up and looked at the small intestine underneath that or posterior to it, that's still greater sac. So where would the lesser sac be now? By the green? That's where they go. Okay, so what I would say is if you slid your hand along the lesser curvature of the stomach here, we know this is the liver, even though we haven't talked about liver yet, but that's the green thing is otherwise known as a gallbladder. That'll become clear the next time. So if we put our hand right through here, just posterior to the liver, our fingers would slide up the anterior surface of the lesser omentum. And if we follow that lesser omentum over to the anatomical right, close to the green thing, right? Then that's where the did I mention this? Epiploic foramen, the little hole that you can put your finger in, that's where the epiploic foramen would be. And then your finger would go into the lesser sac. The greater omentum is attached right here to the greater curvature of the stomach, and now it runs over the transverse portion of the large intestine here, comes down here, and then folds under. I didn't talk about all of this, and it comes back up and then attaches to the transverse colon. So it comes down off of the greater curvature of the stomach, comes back up and attaches to the transverse colon. It goes around the transverse colon, and then it comes together again and forms the transverse mesocolon and attaches the transverse colon to the posterior abdominal wall. Good question. Yes? The greater omentum. Yeah, so here's the inferior end of the greater omentum. It's a free end, so you could literally just grab it with your hand. And then all of this, it's this serosal membrane, and it's double layered. It just has a lot of adipose tissue in it. It's very variable. This is one that's not been affected by adhesions or anything. Sometimes it's all crumpled up and even hard to find. So okay, so that's good. Yes?
No, that's fine.
That's okay.
I think so.
Yeah, so the question is basically where's the visceral peritoneum here? So the greater omentum would be considered visceral peritoneum also. Yeah, and then visceral peritoneum, of course, would be covering the outer layer of all these little loops of the intestine. It would be on the stomach, on the transverse colon. Okay, so let's look at the next picture now and see. Now, what have we done here? We've lifted, that's one of our favorite things today, is to lift up the greater omentum, and we've also elevated the transverse colon. So, of course, we can see now the small intestine, the duodenum, the jejunum up here in the upper right quadrant of the abdominal cavity, the ileum down here. See the transverse colon, which we've also elevated, and then this would be, yeah. So what artery would they be showing here? Sorry? That's a branch of the superior mesenteric artery, yeah. Okay, I think let's just go, okay, now what have we done? How did we do that? We took away the small intestine. What was the dissection step? Okay, so we've transected the jejunum very close to the duodenal jejunal junction, and we've cut the ileum very close to the ileocecal junction. But then we can't get the intestine out, and you call the instructor and say, I can't get this thing out. And they'll say, well, did you cut? Okay, mesentery proper, so this is the mesentery proper right here. They didn't quite go back all the way to the root where it's actually attaching. But, so right. So what else did we cut when we cut the mesentery? Blood vessels, nerves, lymphatics. So what can you tell me about the blood vessels? Where'd they come from? They came from the aorta. I'm thinking a little more specific. Yeah, I'm hearing it, sort of. I'm hearing it again. Superior mesenteric artery, because why? Why would you say that? Because midgut. So the small intestine is midgut, and that's going to be supplied by branches from the superior mesenteric artery. So that's good. So here we have, okay, this of course is descending colon. It's secondarily retroperitoneal. What do we have here? Sigmoid, because it's suspended by this structure, which is, and there would be arteries in there supplied by what vessel? Inferior mesenteric, yep. Oh my gosh, what happened here? A lot, yeah, a lot's gone on. Let's just start superiorly here. And so I know, yeah, we took everything out. Something's been cut here. Esophagus. So the stomach should be right here, but it's gone. Would it be connected right here? What would this be? Yeah, this is probably duodenum, just maybe beyond the pyloric sphincter. And so we have the first part of the duodenum, the second part of the duodenum, third part of the duodenum, this horizontal part, fourth part. This part is secondarily retroperitoneal, so it's attached to the posterior abdominal wall. Here it comes off the wall, and this is where it's been transected to remove it from what part? Yeah. And then so the root of the mesentery has been taken away, all the small intestine. Oh, and we don't even see the ileocecal junction. But look at this area. So this shiny area right here, we see shadowed in back here, we see some branches of the superior mesenteric artery. We also see this, something was right here. What was that? It's been cut. Mesentery, I heard, this is the root of the mesentery. So this is where the small intestine is attached to the posterior abdominal wall. So there are two layers of visceral peritoneum that have just come off of the posterior abdominal wall. This part it's like 6 inches long here, but this is the part that's going to fan out to cover all 20 feet of the small intestine. So down here, we're in the right lower quadrant of the abdomen. And now we see something else. What's this? So now you see how you left this, you took the ascending colon out and you kind of left this scar. Because it's attached directly to the posterior abdominal wall. It had to be dissected off the wall, so you leave this little scar. So the transverse colon went across here, but there's no scar. There's mesentery. Do you see where the mesentery has been cut? The transverse mesocolon has been cut. So that's right here. This is where the transverse mesocolon attached to the posterior abdominal wall. And now we get over here, and we get to the area that would be the splenic flexure. And then we look here and we see another scar. That's the descending colon, so we can see that it's been taken away from its retroperitoneal location, and then something happens right here. Sigmoid mesocolon. Good. And then we see rectum down there. Okay, so that was good. So now we go to Rowan, and does this make a little more sense? No? So this is the stomach. It looks a little bit odd. And of course, you understand why we don't see the pyloric end of the stomach. We don't see the duodenum. We don't really see anything until we get over here to the jejunum of the small intestine, but we don't even see the connection. But we know that in general, the jejunum is going to start over here in the upper left quadrant, and the small intestine will end down here with the ileum in the lower right quadrant. So I don't even see the ascending colon until we get up here. I think here's the hepatic flexure. You kind of see some of the haustra here. Here's transverse colon. And then it kind of disappears. That might be descending colon or splenic flexure, but I'm not sure. So what do I say? Greater curvature, less small transverse. Okay, so you're okay with, and then of course the visceral and parietal peritoneum. The visceral peritoneum is going to be covering all these loops of the intestine. The parietal peritoneum will be lining the inside surface of the abdominal wall. So that's not. Yes?
So I'm gonna repeat.
Uh-huh. Yeah, right here. So the other thing we can mention here, it's kind of like the dog that didn't bark. Like, what's missing from the greater curvature of the stomach? Or I think it's missing. The thing that holds it down, the greater omentum. Yeah, I think the greater omentum, sometimes you open a cadaver and it looks like this, the greater omentum is all retracted up, sometimes it's just off. It'll move around, and if there's an infection or an injury, it'll kind of get itself localized in that area. It's kind of odd, but the other thing is, let's talk about the lesser omentum here. Where would that be? Are you seeing it? Behind, yeah, posterior to the liver. So again, the lesser curvature of the stomach would be right along here. That's where the lesser omentum would be located. So if you put your hand right in that space between the lesser curvature and the liver, then you'd go right on to the lesser omentum. Okay, so I guess this last one, they left the ribs here, the subcostal or the costal margin, and you can also see some of the diaphragm here to give you an idea of how things relate. This structure right here is, yeah, that's the greater omentum, so the stomach is not really showing up here even, but there's that little groove between the lesser curvature of the stomach and the liver, which would be the location of the lesser omentum. And of course, if you reach down here, picked up the greater omentum, lifted it up, then you'd be looking at the coils of the small intestine. So, and then with this, I guess I was just trying to, gives you the idea of, you already know this, the thoracic and abdominal aorta, and then I think I say, yeah, estimate where the celiac trunk and superior mesenteric artery might be. So here's the liver, the diaphragm is right here, So right, somewhere right in this region right here is where the celiac trunk and the superior mesenteric artery would be coming up. I don't think there's anything else there we need to. And then, of course, here are, is just an example of how physicians would often look at the arterial supply to the GI tract, and they'll do this often just to, I mean, if there is a suspected stroke, for example, and they want to find out where it is, this is what they can do. So what have they done here? They've actually put a catheter up and through the aorta and into the origin of the, in this case, the superior mesenteric artery. And here, so here you see the trunk of the superior mesenteric artery, and then you start to see jejunal branches and ileal branches down here. Here are some of those arcades, and then you see the straight arteries. The straight arteries look nicer in the painting than they do here, but you get that impression. And then finally, more superior mesenteric artery. Here's the mesentery's been dissected away, and you can kind of get the idea here how fat-filled it is. And this is not because the person was overweight, it's just, we just have a lot of visceral adipose tissue. This is a vein here, and you see jejunal branches. And then here is a really a nice preparation, showing jejunal branches, the arcades, and then the straight arteries that are supplying. Right, yeah, so this is, again, remove the greater omentum. So the other thing I had here that I think we could work through, I just went back, this is slide number 3 in this slide set. So I have a series of sections, axial sections through the cadaver, and you could probably kind of use these as a guide to look through a region of the thorax. And what we would be interested in then is the esophagus. Do you see where that is here? Here?
Down.
Here, yeah. Goofing on you here. So what would these other structures be here? Aorta. So trachea. I think, so the trachea is going to end like at the sternal angle, like right about here. So I think we're even below the hilum of the lung, or we're just at it. Here come the pulmonary veins here. So we're not seeing the trachea here. We're below that. We have the thoracic aorta, and then this little guy is the azygos vein. And then here's the esophagus. So you can follow that down. That's so it's retroperitoneal here, not retroperitoneal, but it's attached to the posterior thoracic wall in this case. So, and then now we've gone down further. We're not quite down to the costal margin, but already we see the esophagus coming off the posterior wall, and here's where it's attaching to the stomach. Here's the stomach right here. This is liver. This, of course, is lung right here. Diaphragm here. So some of that stuff you've already talked about. But so you can, use this to kind of use your own VHD there and just probe around and see that connection. So, okay, so the one thing I'm seeing here, we see the stomach, and you can see, so the stomach is right over here now. And here's a Rowan image. Here's the stomach. You can see where we're coming through here. What do we have right here? That's the aorta, right? So the aorta actually goes posterior to the diaphragm. Here's the, I don't know, you probably looked at this, the right and left cruce of the diaphragm where it's attached to the vertebral column there. And this is the aorta getting ready to pass through the aortic hiatus. Is this making sense? Yeah. So we continue down now where we see the stomach. We've just gone a little bit lower. This might give you an idea over here on the right. What are we going to be going through right here?
colon.
This is the duodenum, I heard duodenum, yeah. This is the duodenum, and then of course this structure right here is the transverse colon. And that's what this is. Does that make sense? So here's the distal end of the stomach. That's pretty hard to tell just from looking at this section, but then you see this little tube coming off. This is the duodenum, first part of the duodenum. All of this stuff out here is just transections through the small intestine. And then this would be hard to know too. It's over on the left side, so it's right over here. That's the descending colon. That's the superior end of the descending colon. You'd have to have a clue, I think, to know what that. Number 2 is the descending colon. 3 is just loops of the small intestine, and 1 is transverse colon, yeah. Okay? Some of this other stuff like the liver and pancreas we'll talk about. So, say it again. You're all set? So let's go, we're just going inferiorly now. So here's what we talked about before, the kidneys, the right and left kidneys, and they are retroperitoneal organs. They develop in the retroperitoneal space. So let's just think about that for a minute. This is the pancreas. It's secondarily retroperitoneal. This is just a part of, well, just pancreas. So where is the posterior abdominal wall where like the mesentery proper attaches? It would just be right in this space right here. And then it would go around over here. This is the spleen, which is also intraperitoneal. Now I'd be tracing along where the parietal peritoneum is. So when you look at an image like this, you think, where's the peritoneal cavity? There's nothing there. There's no space. You have a lot of adipose tissue in there. But of course, the visceral peritoneum is just around these sections of the loops of the intestine. And then I have another slide that'll give you a better idea of the spaces that actually make up the peritoneum. So here we go down just a little bit further. So you still have the kidneys. Let's look at that aorta. Oof, look at that thing. I'm going to go back up. Did I? Yeah. Here's the aorta again. I was going to point this out. So I've gone just superior by a few millimeters, and we have the aorta, but look what it's doing. It's just come through the aortic hiatus. This branch is the celiac trunk. And I know that because I cheated. I made the slide. If I just showed you this section, you probably think, okay, that's very likely that's either the celiac trunk or superior mesenteric artery, and that would be good. Here, oh, did I just go the wrong way again? Yeah, so now here's what we were just looking at, the celiac trunk. Now I'm just going to go slightly inferior, and here's another branch coming off. And you can see, remember I said well, I shouldn't even say this, and we haven't talked about glands, but this is the pancreas, and the pancreas is going to stretch over here to the left. But the pancreas would be covering the origin of this artery right here. That's the superior mesenteric artery going to the midgut. So again, we have a couple sections of the transverse colon. So the transverse colon in this VHD man, Mr. Jernigan, is kind of U-shaped. It droops down in the middle, so we're still above the part here in the middle. And then this would be the ascending colon. We're getting very close to the hepatic flexure. And then here would be the descending colon over here on the left. Okay? And now we get down, we're getting down, we see lots of loops of the small intestine and a lot of adipose tissue and a lot of vessels here that are running through the mesentery on their way to the GI tract. The arteries would be branches of the superior mesenteric artery. Here we still have the aorta here, inferior vena cava. And then we get down into the pelvic cavity. So basically, we know the rectum is down there, we're not gonna do too much more. And here's the, if I recall, I think this was the sigmoid colon, some of the sigmoid colon down here, but we're getting into the rectum. And then, so what I wanna do is show you this one. I don't think there's anything, yeah, I was gonna, let me just again ask the question or pose the question, where's visceral peritoneum, where's parietal peritoneum, where's greater sac here? So you really can't see those spaces. Now this man, the way the slices were prepared, he swelled a little bit, especially his brain, but also it just seems to me, even the abdominal contents. But we know, we see the transversus abdominis muscle here, rectus abdominis. We know on the posterior aspect there of the abdominal wall, we have parietal peritoneum. We know we have visceral peritoneum surrounding the loops of the intestine, but we don't really see what we would call peritoneum itself. But when we look at this section, now you kind of can. This is a cadaver that's just been sawed through. He wasn't frozen, thawed repetitively. So now, especially over here, this is the liver, this is not the GI tract. Here's the stomach, here's the duodenum coming off the stomach. Now that I said that, yeah, this is for sure the stomach. Here's the posterior surface of the abdominal wall, and now you can see a little bit of space there. That would be part of the greater sac. And you can even see here, all these spaces. This is all part of the peritoneal cavity. That doesn't show up so well. And then the mesentery itself is going to be attached to the posterior abdominal wall. That would be somewhere right along here, because the pancreas, which I know we haven't talked about yet except just sort of in passing, it's retroperitoneal. So this is where the mesentery and transverse mesocolon would be attached. It's easy to see now how we would consider the kidneys as retroperitoneal organs. Let me ask you this, what's this dark triangular area? Good. They show up nicer in this section than they do in the VHD section. So I think that's what I wanted to introduce the VHD to as far as the GI tract. I wanted to go through those dissections, those atlas images of the dissections. I think you did well, yeah, with those. General question, yep. Yes. Yeah, for now, so some of I'm thinking pancreas. I mentioned the pancreas a couple times in passing. So that's like your first introduction to the pancreas, but hasn't been the main theme yet, but next week it will be. So you kind of have a heads up on that. Are there other structures in particular? Like I won't ask you the transversus abdominis muscle. You might want me to, but you know that already, because you don't forget these things, right? I'm joking, So the text on the slide certainly guides you to the main story of the day. In passing, I may have mentioned other things, but I'm kind of just to highlight how it relates to the main story. So I think about this a lot. I know I've had a lot of questions, like in terms of what you need to study. I would really like it, and I know this is an old man talking, but if you would listen to me talk and then go back to your textbook and really just, I know medical students very well, and they look at me and it's like, you have a textbook? And I understand also that that's kind of the environment that we create for them, and I would be doing the same thing if I was a student these days. But so I try to, with the words on the slide, I try to guide you to what is of